Hi, this is Elliot Fishman, and welcome to our latest podcast. And this is going to be on the CT evaluation of liver masses, focusing on key differential diagnosis pathways. So we're going to take a look really carefully, and you think about it, the goals of CT of the liver, and truthfully the goals of CT of the pancreas and kidneys and bowel, is always the detection of the presence of disease. That's the number one goal. Is there something going on? Defining the extent of the disease process, and then looking based on the appearance of the etiology of the disease process, and thereby help with further decision making in patient management. Do we need a biopsy? Do we need a follow-up? Do we need an MR? Do we need surgery? What do we need to do? So CT really provides all of the information we need and does it in a very simple format. Now, one of the things we've said for many years as well, increased lesion detection, which happens as scanners get better, does not necessarily mean a more accurate diagnosis. The reality is most of the sub-centimeter lesions are benign cysts or hamartomas or hemangiomas. So simply saying there's a lesion present in a patient with colon cancer can be more problematic. Does the patient have a simple benign lesion and the patient's colon cancer can be resected and maybe it's stage 1 or stage 2 disease? Or does the patient have stage 4 disease with liver mets? So it's very important to go far beyond just detection and really go to classification. And in this lecture set that we're going to do, which will probably be 4 or 5 parts, we're going to spend a lot of effort trying to recognize specifically what lesions are. Now, if I'm doing a dedicated liver protocol, I'll still give water. I want to distend the stomach. I want to get a good look at the stomach and bowel and make sure I'm not missing any pathology there. And water is easily tolerated. I give essentially 750 to 1,000 cc's of water within 30 minutes of the examination. And then, of course, to look at the liver, you need IV contrast. In the old days, Mike Federle used to speak about how you always also did non-contrast scans. The main reason for doing non-contrast scans, he felt, was looking at cirrhotic patients and trying to figure out if regenerating nodules versus hepatoma or the lesion's dense. The main reason for doing non-contrast CT scans, or at least several of them perhaps, is just to get a density of the liver without contrast. Sometimes fatty infiltration of the liver is easier to quantify on a simple 2-slice study with non-contrast scans. So every once in a while we'll do non-contrast scans. Also, in cases where you think the liver may be extra dense, let's say hemochromatosis or due to amiodarone, a couple non-contrast scans will be helpful, but the reality is most of our studies are simply going to be IV contrast studies. Now, with IV contrast studies, if I'm looking for rule-out liver pathology, I'll always do a dual phase acquisition, which means arterial phase at about 30 seconds and venous phase at about 70 seconds. Occasionally, we'll get late phase imaging, but that's rare. We do it in cases like when we're thinking about cholangiocarcinoma, perhaps. Cholangios get brighter on later phase imaging, so that can be helpful. Also, not in the liver tumor category, but when you're doing a CT of the liver pre-transplant, you'll do arterial, venous, and delayed. So most of the time, it's 2-phase. Now, if you ask the question, do I always need to do arterial phase? I think it depends on the scenario. When I'm working up a lesion and want to look at its characteristics, the answer is yes. If you're following a patient with suspected or known liver metastasis from colon cancer mets always show better or almost always show better on venous phase. And so in those scenarios, arterial phase will not be necessary. But when you're looking at the first study, the arterial phase can indeed be very, very helpful. Now, in this talk, and if I speak about the liver in general, I could focus things on applications: benign tumors, malignant tumors, parenchymal liver disease, infectious disease. Recently, or within the last year, we did a talk on parenchymal liver disease. So this talk is going to focus on hepatic masses, both benign and malignant. I'm also going to speak a little about infectious disease, liver abscesses to be specific, mainly as a way of showing you how at times liver abscesses and liver tumors can overlap, and it can be somewhat of a challenge in making the right diagnosis. So that's what we're going to focus on. Now, in terms of incidental liver lesions, this was a white paper from a few years ago that I was part of. It was the redo of the initial ACR white paper. And the question here was incidental liver masses. And you could see division of the lesions was based on size, under 1 cm, 1 to 1.5, or over 1.5. Key things to look at were patient risk. A patient where an incidental finding in a 25-year-old is seen and it's 5 millimeters in the liver, you could be pretty certain without thinking a lot it's going to be benign. Of course, if this patient has colon cancer, you would worry a little bit more. It also shows, when you look at the categories, the importance of recognizing the features. Benign imaging features like hemangioma versus features that are either concerning for tumor, like neovascularity, and we're thinking hepatoma, or patients who have cirrhotic livers where the concern is much higher than it would be if you were looking at a patient with a normal liver. So let's look at some of the benign lesions first. Now, I put hepatic adenoma here. Hepatic adenoma crosses between benign and malignant. Hepatic adenomas can act aggressively, we'll speak about them later, and spontaneously bleed. Hepatic adenomas can also transition into hepatomas. But the first three are surely going to be benign. When you think about cystic hepatic lesions in general, developmental is one category. Hepatic cysts are the most common. Biliary hamartomas, polycystic liver disease, often associated about half the time with polycystic kidney disease, Caroli's disease, and the unusual ciliated hepatic foregut duplication cyst. We'll speak about neoplastic lesions, the biliary cystadenoma, cystadenocarcinoma category. Remember, we used to look at these cystic lesions with nodules, try to determine which were benign and which were malignant. Now all of these need resection because they're considered malignant. We'll talk about cystic liver mets. Classically, cystic liver mets occur in patients with ovarian cancer, patients with GIST tumors, and perhaps patients with melanoma. And of course, hepatoma can be very cystic. In part, it kind of looks like it's necrotic, but cystic and necrotic in the face of hepatoma tend to overlap, of course. We then speak about cystic lesions in the inflammatory category. Pyogenic liver abscesses, amoebic liver abscesses, classically cystic, enhancing rim, right lobe of liver, hydatid disease, cystic with septations in multiple, and of course fungal disease, usually in immunosuppressed patients, multiple, commonly in both liver and spleen. In the liver and in the spleen, they're small. You're not going to see 5-centimeter microabscesses. There's a reason they're called microabscesses. They're multiple and typically under a centimeter in size. We talk about other cystic lesions. It can be trauma-related, like hematoma, myeloma, or seroma. And when I say trauma, I should also put down surgery-related, complications post-liver resection, hematoma, myeloma, and seroma. Now let's look a little bit more specifically at hepatic cysts. They occur in at least 10% of patients. The more carefully you look, the more you see, particularly the smaller lesions. They're water density with sharp margins. They can be single, but commonly are multiple. And here's just a simple example with lesions in right and left lobe of the liver. They have no enhancing wall. They're typically showing no calcification. A cystic lesion with rim calcification typically is an old hematoma. You can see the density looks very much like the water in the stomach. Occasionally you can see thin septations, but obviously a benign leave-alone lesion. Hepatic cysts typically do not distort vessels, but like anything that gets large enough, and hepatic cyst can be 20 centimeters, anything when it gets large enough can displace vessels, but does not cause any neovascularity. Here's a good example showing you the venous map with MIP and volume rendering of a large hepatic cyst. Well-defined, slightly pushing the vessels, but no significant irregularity of the vessels. Here's another lesion. You can see there is the suggestion medially of perhaps some rim enhancement. Now, I told you that cysts do not enhance, but what happens is when cysts get large enough, they compress the normal liver parenchyma, And what you end up seeing is a rim of normal parenchyma that's being compressed. And you can see that very nicely here, because on these images, which include the MIP image, you can see the hepatic artery is stretched. So with a large cyst, you stretch the arterial structures, and you have that mass effect against the artery, and it's the artery you're seeing at the very edge. So that becomes important to recognize. Polycystic liver disease can be anywhere from a few cysts to total replacement. Patients can present with liver failure. There is no increased incidence of carcinoma in patients with polycystic liver disease. You can see it very nicely here. And then you look carefully at the kidneys. In this case, the patient's kidneys are okay. I mentioned about half the patients with polycystic liver disease have polycystic kidney disease, and the other way around also, about half the patients with polycystic kidney disease also will have polycystic liver disease. And again, you can see even in the same patient with polycystic liver disease, the difference between the size of the cysts from several millimeters to 10 centimeters. So it can be very, very variable, and that's important to recognize. Now, I mentioned before that hepatic cysts do not have enhancement, and I showed you an example where the vessel, the artery, was compressed. But it's also important to recognize that if hepatic cysts are critically located centrally, they can push on the IVC and can push even on the portal vein, and therefore you can see some perfusion changes. So in this case, where you're tempted to say, oh my goodness, it must be an abscess, look at the perfusion changes right lobe of the liver. There's a question of a thick wall, and a thick wall always makes me think potentially of an abscess when it's cystic. This is simply a large cyst that was compressing the patient's IVC. This patient's initial presentation, in fact, was lower extremity edema because of IVC compression. So it's an important thing to recognize. Now, if you ask what things can look like hepatic cysts, here's a simple example of a patient with hepatic resection. You can see some clips, and then you see what looks like a cyst. But in the right scenario, post-op patient, you're thinking biloma versus hematoma. And this has the classic look of a biloma. Here you can see it very nicely again on the coronal views. Now, as I mentioned, when you look at cystic lesions, we also speak about malignancy. When you look at this case, you're not going to confuse this with a simple cyst. Look at the nodularity in the cyst wall, some faint calcifications, but it's the irregular enhancement, all of the irregularity. This is a cystic tumor. You could potentially think about an abscess in the right scenario, but this is more classic for metastatic disease. Theoretically, it could be a cholangiocarcinoma or even hepatoma that wasn't vascular, that was necrotic. This was metastatic spindle cell sarcoma. You can see on the coronal views nicely with the MIP, the neovascularity in the wall. So the majority of the lesion is at first glance and even at second glance cystic, but it's the irregular vessels, the nodularity, the thickening of the wall that tells you this is not a simple cyst, and the neovascularity. Again, I'll show you many examples, but I do like MIP imaging when looking at liver lesions. It really shows me the interface of the lesion well with the remaining liver. It also accentuates any vascularity. So things like neovascularity here are particularly well seen. At times on axials or coronal, you don't quite appreciate it quite as much. And here's the same case on venous phase imaging, the nodularity in the wall of the cystic lesion, very classic for metastatic disease. Here's another patient with a GIST tumor, a small bowel GIST, to be precise. We mentioned before that GISTs are one of the tumors that go to the liver, be it from stomach or small bowel or even colon. The Mets are often cystic, like in this case, but there's a thickened wall, there's some increased density centrally. Now, of course, we always remember and we always think about an abscess because here's a cystic lesion, but you see lots of perfusion changes in the liver around it. And this was a liver abscess. Amoebic abscess especially occur in the right lobe, but when you see so many perfusion changes around a liver lesion, there's no way you're going to put it in the category of a simple cyst. Now, with perfusion changes, you could think about a cystic metastasis. That makes a lot of sense, but you also have to consider an abscess. Then the importance of clinical history and potentially a biopsy will be necessary. In a post-op patient, here's a ring-like lesion. It's cystic, but you have a ring around it, and that appearance is very good for metastasis at times. But in the post-op patient, you got to think about an abscess. And we've seen this be confusing, particularly in pancreatic cancer, and you often will have multiple lesions present, more common in the right lobe, typical post-operative abscesses. Now, of course, a post-op abscess that has air bubbles like this and is cystic, there's not a very long differential. Air fluid levels, air bubbles, you're dealing, I guess in theory you can have a fistula, but even with a fistula, this is always going to be a post-op liver abscess. Now, when we think about multilocular cystic hepatic masses, the differential, we've mentioned cystadenoma versus cystadenocarcinoma, hepatoma, metastasis, the unusual mesenchymal hamartoma, and the very, very unusual inflammatory myofibroblastic tumor. Now, biliary cystadenomas and cystadenocarcinomas are usually in middle-aged female patients. Cystadenomas may transform into carcinomas, so all of them are resected. The CT findings include a large, solitary, multilocular cystic lesion with well-circumscribed smooth margins and internal septations, often with nodules. Enhancement and or calcification may occur in the cyst wall. In fact, when you look at this biliary cystadenoma, the differential diagnosis that comes to mind to me is also hydatid liver disease. Hydatid disease are cystic with multiple septations and commonly involve the liver, though usually the history of foreign travel, if you're a U.S. citizen, or if you're certain parts of the world, would be helpful in making that diagnosis. Here's another biliary cystadenoma, again very similar. Large cystic lesion, well-defined, multiple septations. Here it is on the coronal view. Again, if I had to do a differential, I'd throw hydatid in there. It almost looks like a serous cystadenoma of the pancreas, in fact. Here's another biliary cystadenoma. This was unusual because there's not any real septations beyond a tiny septation. It almost looks like a hepatic cyst. But cystadenomas, and in this case a cystadenoma, can look at times very non-aggressive and can be a very challenging diagnosis. When you look a bit closer at the venous phase of the lesion, there is some thickening of the wall and several tiny septations. But you could see that you might think about a complex cyst, but cystadenoma is something you should be considering in this appearance. Other things you might have considered, could this be a colodocal cyst? But I don't see a dilated common duct or communication with the common duct. Now, when you think about the most classic lesion, and the one that I remember when I first was into CT, people would speak about a lot because we always would try to distinguish hemangiomas from other malignancies, and we were learning. In those days, hemangiomas, you would follow till a lesion would fill in entirely, which meant you would wait about 30 minutes. But I'll tell you what we'll do. Let's just take a short break here, and we'll come back and speak about hepatic hemangiomas. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.